Hi, my name is Abigail Tazzyman and I'm presenting a paper on the implementation of new roles in primary care. I'm presenting this on behalf of myself and my co-authors, whose names are listed on the slide. I'm just going to begin by providing a little bit of background. So this was a qualitative study into the introduction of new non-medical roles into primary care in a UK metropolitan county. The primary care workforce within the UK is understood by many as being in crisis. And ageing populations, increased complexity of health needs and rising cost of treatment, alongside funding reductions and a lack of investment in workforce, have all been identified as factors contributing to this crisis. In addition, difficulties in the recruitment and retention of doctors and nurses has further exacerbated this situation and led to significant workforce shortages within primary care. One approach to tackle this workforce shortage and meet the unmet healthcare demand has been the introductions of new roles within the sector. In practice, what this has meant is the introduction of clinical and non-clinical staff from different professions into primary care to take on some of the doctor and nurse workload. And it is hoped that this will increase patient satisfaction and access, as well as proving to be cost effective. The introduction of new roles as a policy approach has intensified in recent years, and the NHS long-term plan and GP contract 5-year framework, both brought in 2019, are good examples of this. This paper builds on work on the professions and on boundaries. The professions are predominantly understood as established occupations that are seen as knowledge gatekeepers, usually holding specific qualifications and able to self-regulate and have a large degree of professional autonomy. Key to professions are their boundaries. Boundaries are that which distinguish categories and regulates the interactions between them. Boundaries are important because they define professions' access to material and non-material resources such as power, status and resources. It's important to note when looking at professional boundaries that they're not static. They're continuously evolving and require ongoing work in order for their parameters to be maintained, changed and defended. Through boundary work, workforces are able to change their remit, and this is understood to be done so in 4 directions. The first of these are diversification and specialisation. So this is the expansion of professional boundaries within a single discipline, so within a profession. The next of these are horizontal and vertical substitution. So this is the movement of a discipline outside of its traditional boundaries to take on tasks that are normally performed by other health service providers. Capacity to carry out this boundary work and to diversify, however, is not equal. And professional hierarchy determines who is most able to change their boundaries and perhaps more significantly, who benefits from the changes that are made. This presentation is based on semi-structured interviews and focus groups that were carried out with interviewees at both a strategic and an operational level. In terms of the study, we targeted 5 new roles, which were care navigation, paramedics, pharmacy technician, physiotherapist and social prescribing link worker. Now, while I'm sure most people are familiar with paramedics, pharmacy technicians and physiotherapists, I'm just going to give a brief description of the other 2 roles, as I know these are newer and less familiar. So, care navigation is an enhanced role and it's usually taken on by GP receptionists, and it's based on active signposting. So this entails the signposting of patients to appropriate professionals for their needs and away from GPs. Social prescribing, while there's no agreed definition, usually involves the referral of patients with social or practical needs to non-clinical and community-based support. In total, we interviewed 8 to 5 participants between August 2018 and July 2019 and recruited these through purposeful and snowball sampling. In terms of our analysis, this was based on an initial coding framework with the addition of inductive codes, and we followed this up by comparisons of the findings across the roles in order to identify similarities and differences. So I'm now going to go on to talk about our findings, and I'm going to focus on two key areas. So this is ambiguity and role boundaries and hierarchy and power. Across all the interviews, there was very little clarity on what the new roles entailed and what their remit was. This was reported from both those who occupied the new roles, as well as those who worked with them, employed them, and promoted them. The ambiguity that surrounded the new roles meant that those occupying them, as well as the practices that employed them, both found their expectations of the new roles to not be met. And in the quote at the bottom of this slide, you can see just an example of this lack of understanding about roles coming in, even when they were from established professions. The lack of understanding around role remit and the ambiguity around the roles was often described as being exploited by practices. So what this entailed was individuals occupying new roles at times being given unsuitable work, so work outside of their remit, as well as poor quality work that resulted in de-skilling, and was usually the work not wanted by others who were more established. And in the quote on this slide, you can see examples of this. It was very difficult without boundaries around what roles were for those who occupied new roles to say no, especially given the relationships in terms of power and hierarchy that were at play, both in terms of more senior professionals, but also in terms of GPs being their employers. And so we start to see here the importance of context and power in relation to ambiguity surrounding the new roles that had been brought in. Ambiguity around role remit and an absence of recognised professional boundaries meant that individuals frequently engaged in ongoing processes of negotiating their roles. These negotiations were strongly impacted by hierarchy and the associated power relations. And we see this in both roles' abilities to determine their remit, as well as the rewards they received for their work and the conditions of the job. So, for example, roles were brought in with a focus on helping GPs, and this, combined with a lack of guidance on what roles were, meant a situation was created in which there was no clear career pathway for the new roles coming into primary care, alongside insufficient training, mentoring and support. And you can see this in the quote that's on the slide. In addition to this, the context of primary care meant that many also felt professional isolation, and this further exacerbated their feelings of disempowerment and weakened their negotiation powers. Across the multiple roles being introduced, there was, unsurprisingly, variation of experience. This reflected the establishment and hierarchical position of the roles being introduced within a broader healthcare context. So in essence, it's meant the more established a role was outside of primary care, the better able that role was to negotiate its work and remit and its working conditions. So we can take care navigation as an example to illustrate this. And the quote on this slide is a good example of this occurring. So all other professions except care navigation, which also wasn't a profession but was rather an occupation, had chosen to take on the role that they had within primary care. And they also had options of work outside of primary care, so from secondary and community care, for example. In contrast, care navigation was a role that had usually been put onto GP receptionists and upskilled, who had been upskilled to take on this role. It increased their workload, the risk and responsibility of their work, and often meant that they faced abuse from patients. In addition, many of those occupying this role felt they hadn't received sufficient training, and so they didn't have the knowledge to safely do the work that they were supposed to be doing. Despite this, however, there was no material reward for this extension of the role that they had previously done as a receptionist, so there was no increase of pay and no increase of benefit. So while the receptionist role had extended in becoming care navigators, because they were not those who decided whether that role would expand or change, it meant they also weren't those who benefited from the change to their own roles. So the power relations at play here meant that most remit change was instigated via substitution. So it was based on those higher up the hierarchy casting off what they didn't want. Diversification and specialisation did occur as established professions moved into primary care, but it's important to note that they didn't have the power or position to bring about this change themselves. They were able to come into primary care and expand because they were allowed to do so by the doctors that worked in that sector. The introduction of new roles into primary care involved the redistribution of work and the redrawing of boundaries. Our study made evident that professional hierarchy in primary care significantly impacted how new roles were implemented and the boundary negotiations that took place. Power and hierarchical position to a large degree determined voice and negotiation power, and so the boundary change that was able to occur. Ambiguity of role was something that was exploited in this context, and context was very important. There's an interplay here of professional hierarchy and employment relations. It's important to note that GPs were not only at the top of the professional hierarchy, but they were also employers in this context. In addition to this, there's also consideration needed for how new roles are brought in and created and how they're designed, in terms of the long-term sustainability of these roles and recruitment and retention within primary care. Thank you very much for listening, and if you have any questions or comments on this presentation, please add them as comments below the video.